Now for RA versus OA. Osteoarthritis, or OA, occurs when the protective cartilage cushion on the ends of the bones wear out over time, resulting in bone-on-bone friction, causing massive pain. Now this is very different than rheumatoid arthritis, RA, where the body attacks its own joints and body, causing systemic inflammation. So the memory trick, think OA is ouch pain, bone on bone rubbing, and RA is rude pain, the body's attacking itself. So rude. So let's cover RA first. Rheumatoid arthritis. This is the autoimmune disorder where the body attacks itself, mainly attacking the joints, causing major inflammation and deformity, notably seen in the joints of the hand, like the knuckles. But RA can also involve other organs like the skin, eyes, and lungs, as collateral damage when the body attacks itself. So Hesse mentions, a patient with rheumatoid arthritis asked the nurse about her condition. On which knowledge does the nurse base patient teaching? Rheumatoid arthritis is thought to be an autoimmune disorder. And Kaplan mentions, a client asked the nurse, what is the difference between rheumatoid arthritis and osteoarthritis? Which response by the nurse is best? Rheumatoid arthritis is a systemic disease, and osteoarthritis is not. Now, in terms of diagnostics, rheumatoid arthritis can be very difficult to diagnose since early signs and symptoms mimic those of many other diseases. So imaging like X-rays and MRIs are typically used, but it's very hard to diagnose during early stages. So a synovial fluid aspiration is used, where we take fluid out of the joint for testing. And arthroscopies provide direct visualization of the joint cavity, and samples can be taken, as well as blood tests. So write this down. An RF, or rheumatoid factor, which is an antibody inside the blood, can indicate RA. And we have two other tests which mainly indicate inflammatory processes in the body, like an ESR, which is erythrocyte sedimentation rate, and a CRP, C-reactive protein. But again, these just measure general inflammation inside the body. So Hesse mentions, a patient arrives at the clinic with left knee pain that began 1 month ago. The X-ray examination and MRI were inconclusive. The nurse anticipates which procedure will occur next, an arthroscopy. And a second question here. Which tests performed to confirm rheumatoid arthritis, RA, and rule out other diseases? Select all that apply. Synovial fluid aspiration, the rheumatoid factor, RF, and the ESR, erythrocyte sedimentation rate. Now for signs and symptoms of rheumatoid arthritis. The early signs include fatigue, anorexia, including weight loss, and morning joint stiffness. And then it progresses into more severe, symmetrical pain and swelling in the small joints of the hand, including the fingers. A key term is swan's neck or boutonniere deformity. We see contractures of the joints, which is a very high priority, since this causes shortening and deformity of the fingers. Now a big one here is joint pain. Clients will get relief with activity and have more pain at rest. So write that down. This is very different than osteoarthritis, where we see more pain with more activity. So again, write it down. For RA, we have pain relief with activity and more pain at rest, which results in deconditioning of the joints due to decreased muscle strength. Now Saunders mentions, suspected rheumatoid arthritis. The nurse would expect to note which early signs and symptoms. Select all that apply. Fatigue and morning stiffness. And a second question here. Assessment on a client with RA. The nurse checks for which assessment finding that is associated with RA. Systemic symptoms such as fatigue, anorexia, and weight loss. Big key terms right there. Okay, now for patho test tips. A few key terms that you should write down and know for your pathophysiology exams. So first up is inflamed synovium. Fancy words for the synovial membrane, the soft tissue that lines the space in between the joints. Next is pannus, which is a hard tissue around the joints. Now, this is a new abnormal layer that is made up of fibrotic or fibrovascular tissue or granulation tissue. Basically, it's scar tissue from all that inflammation, making the joints harder to move.
Next, we get a loss of cartilage, that supportive connective tissue between the joints, as it becomes destroyed when the body's attacking itself. And another key term here is ankylosis, not to be confused with alkalosis. Ankylosis is the stiffening and immobility of a joint due to the fusion of bones. So basically, once all the cartilage is gone, bones will try to fuse together. And lastly, we have iron deficiency anemia due to the chronic inflammation of the joints. This can lower the production of red blood cells in the bone marrow, as all this inflammation and destruction of the joints is going on.
Now, switching gears to osteoarthritis. The pathophysiology is pretty simple. As mentioned before, this is progressive degeneration of the protective cartilage, which acts like a cushion at the end of the bones, resulting in bone-on-bone rubbing, causing massive pain. So again, the memory trick here. OA, think ouch pain, bone-on-bone rubbing. And RA, think rude pain. The body's attacking itself. So rude. Now, for the causes and risk factors of OA, it's very common in older age as the body wears down, as well as obese clients who have a lot of extra body mass, and smoking and even repetitive stress on joints from high impact activities, like jumping or running on hard surfaces. Now, the signs and symptoms are simple. They include joint pain and stiffness, just like RA. But the key difference is crepitus, that crunch sound, as the bones grind together. So remember, OA is that ouch pain. So the NCLEX tip here is pain more with activity and relief with rest. The exact opposite of RA. So make sure to write that down and know the differences. Saunders mentions the client with osteoarthritis. Which clinical manifestations are associated with this disorder? Select all that apply. Joint pain that diminishes after rest, and joint pain that intensifies with activity. Now, in terms of the joints, OA will typically only affect one joint, usually the larger joints, like the hip or the knee. But there will also be joint swelling in the hands, seen as node formation in older adults, like Herbeden nodes, happening in the distal finger joints, and Bouchard's nodes, happening in the proximal joints, which are typically not really tested on directly.
Now for some patho test tips specifically for osteoarthritis. A big key term to write down is osteophytes and bone spurs, described as bony lumps that grow on the spine and around the joints. Osteophytes can grow from any bone in the body, but they're mostly found on the neck and shoulder. Now the next key term is cysts that are subchondral. Now, if you didn't know, a cyst is a sac-like pocket of membranous tissue that contains fluid, air, or other substances. So this type of cyst is a bone cyst that is caused by osteoarthritis and may require aspiration, or basically drawing the fluid out. The next key term is a loss of range of motion, that ROM, as the joints become very, very stiff from that loss of cartilage. And next we have pain with weight bearing. This is huge. So like lifting heavy objects or with exercise. So naturally, weight-bearing joints and fingers are affected most. For example, the knee joints, the joints in the hands, the wrist and elbows, as these joints commonly bear weight for normal daily activities.
Now, in terms of pharmacologies, this is tested a lot. OA is very similar to RA, so we take NSAIDs and steroids ending in zone, like prednisone. Again, both are used to decrease swelling, but really the most tested here for OA is glucosamine, to help reduce pain and joint tenderness in clients with arthritis. So let's play that segment from our pharmacology series. As far as joints, we use glucosamine, which improves joint function in osteoarthritis patients. But guys, we watch for hypoglycemia when taken with other anti-diabetic meds. Now, ATI touched on glucosamine as key term treatment for arthritic pain. Lastly, common surgical interventions for RA and OA is a total knee replacement, also called a total knee arthroplasty. It's a surgical procedure to replace the knee joints, commonly done for both OA and RA. Now, post-op care, this is huge. There's a big risk for blood clots in the leg, known as a DVT, as major swelling in the affected knee blocks good blood flow. so clients will typically be resting in bed for about 3 to 4 days after surgery. Elevate the entire leg as straight as possible, above the level of the heart, to decrease the swelling. Now, key terms here. Never place a support pillow under the new operative knee. Huge NCLEX tip. This can cause blood stasis as the dependent downward facing toes don't get good blood flow, leading to a DVT. And another key term here. Early weight bearing on the leg with ambulation is recommended, and flexing the foot every hour. This can help faster recovery and prevent DVTs. So Kaplan mentions, a nurse is providing teaching for a client who just had a total knee arthroplasty. Which of the following instructions should the nurse include? Flex the foot every hour when awake. Yes. And always ambulate early. Bearing weight on the knee with ambulation is recommended. And again, never place a support pillow under that operative knee. And lastly, we also prevent DVT blood clots by giving blood thinners, like heparin and warfarin. Now the key term is to start the client on both at the same time inside the hospital, since heparin works in a hurry and warfarin has a weaker start. So heparin helps to thin the blood faster, as warfarin is taking a few days to catch up. But we cover more of that in our pharmacology course. Alright, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for scoliosis. For the pathophysiology, think S for scoliosis as S for an S-shaped spine, also called lateral curvature. So write that down. Big NCLEX tip. We get abnormal sideways curvature of the spine. So write it down. Lateral curvature is that S-shaped sideways spine. Now for the signs and symptoms. This S-shaped spine can cause mild to severe pain, and the stiffened spine can make it hard to move. In severe cases, it can cause deformity of the chest cavity, similar to what is seen in kyphosis. Now, it's first noticed during periods of rapid growth, especially in, key terms, adolescent females, ages 10 to 12. Huge NCLEX tip. Screening is done for schoolgirls between those ages and boys between 13 and 14. So pause the screen and write that down. Periods of rapid growth and adolescent females ages 10 to 12. Now for diagnostics. It's done by physical examination of the back. We measure the Cobb angle to determine the extent of the deformity. And x-rays of the back can be taken as well. Now for causes and risk factors. The underlying cause is often unclear, thought to be from a possible defect in composition of intervertebral discs, the little squishy shock absorbers between the spine bones, often seen in individuals with neuromuscular disorders like cerebral palsy or muscular dystrophy, where muscle mass is lost. And it's often seen in Marfan syndrome, a genetic disorder that affects connective tissue. So a little side note, these clients should avoid participating in contact sports. Big NCLEX tip for Marfan syndrome. A lot of questions ask about the priority topic for a child in Marfan syndrome, and it's not monitoring for scoliosis. Rather, it's avoiding contact sports. Just a little side note and a big NCLEX tip for you. Now for treatment. It includes physical exercise to limit the disease progression and maintain range of motion. So a big tip right here is social interaction. This is vitally important for adolescent age groups to provide acceptance and belonging with this S-shaped spine. So big NCLEX tip, write it down. Social interaction, we must ensure client visits friends. It's very important for the younger population to prevent isolation and loneliness during recovery. Huge NCLEX tip right there. Now, don't let the NCLEX trick you. The most important thing is not to keep up with schoolwork here. Well, unless you're in nursing school. Just kidding. Now, the next thing is fixing braces using a Boston brace. Write that one down. This can sometimes fix the deformity for children and young adolescents. So we always make sure to wear a cotton shirt under the brace at all times. Huge NCLEX tip for Boston brace. This will maintain skin integrity and avoid skin breakdown. And lastly, surgery may be used in rare situations, but it's typically not tested on the NCLEX. Alright, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guide.